Good evening. My name is Alastair Dick. I'm a consultant orthopaedic surgeon specialising in young adult hip surgery, and it's my pleasure to talk to you this evening about hip impingement, its presentation and management as part of the ISEH annual conference. So to run through what we're going to discuss, we'll briefly introduce the concept of FAI. We'll talk a bit about its presentation, the clinical and radiological assessment, treatment modalities, and then briefly about the outcomes of the management of this condition. So femoral acetabular impingement was first described almost exactly 2 decades ago by Reinhold Ganz and the Bern group in Switzerland. Initially, it was described as the abnormal contact between the proximal femur and the acetabular rim, leading to lesions of the labrum and/or acetabular cartilage. Now, as our understanding of this condition has developed, more precise definitions have come along, and most recently in Warwick there was agreement on this statement here to try to sum up the condition as a motion-related clinical disorder of the hip with symptomatic premature contact between the proximal femur and the acetabulum. Now, key to that was the consideration of a triad of appropriate clinical symptoms, clinical signs, and imaging findings, all of which need to be present for the diagnosis to be made. The reason primarily for this is that many people will have morphological abnormalities or variants, which certainly would put them at risk of having impingement, though in the absence of symptoms, we wouldn't consider them to have this condition. There are 3 main described types of femoral acetabular impingement classically. Cam-type morphology, as we can see in the cartoon in the top right, is when the head-neck offset is abnormal and reduced with a often anterolateral bump on the femoral neck. That can cause impingement very potently. Pincer is when you have extra bone on the acetabular side, and a mixed type picture is when both are present. The anatomical specimen here on the right demonstrates cam-type morphology and the injury that can cause to the cartilage of the acetabulum as well as the labrum by a direct abrading effect. We are understanding that there are more than just these causes of impingement, most importantly perhaps version both of the acetabulum and of the femur. And we'll talk later about the importance of clinically assessing these, radiologically assessing these, and considering addressing them if appropriate with the management of this condition. Though impingement can also arise post-traumatically, post-childhood hip pathologies such as a slipped capital femoral epiphysis or Perthes disease, and also profunda and protrusia acetabulae with very deep hip sockets are a form of global overcoverage which can cause an impingement type phenomenon. So moving on to the presentation, the cardinal sign and symptom is of activity-related anterior groin pain. Patients will often localize this very precisely. They will often point to where they feel it, and it often has a sharp pincing or lancing type quality to it. Patients often also complain of a focal deep aching pain on aggravating activity. Often there's no particular injury or trauma which precedes it. The patients may describe feeling they had a groin strain which just doesn't get better on its own and insidiously just slowly deteriorates. There are sometimes mechanical phenomena, so catching is common. Also, we sometimes hear patients complain of popping, locking, grinding, or clicking in the hip. And also, patients may be aware of stiffness, particularly in internal rotation. This may progress as the disease gets worse. This cartoon from Clohesi demonstrates that it's often pain is felt in the groin, but not exclusively. As we can see, a good proportion of patients also complain of pain in the lateral hip, also the lower back, buttock, and anterior thigh. It can also be felt in the knee, though the most common clinical presentation is of pain within the anterior groin. Moving on to the clinical assessment, patients will often demonstrate their pain using coordinate fingers, trying to point to where deep inside their hip they feel the pain, or using the C sign where they clasp the side of the hip and their fingers point towards the anterior groin, again demonstrating where they feel the deep discomfort. In terms of the clinical assessment, gait is important to assess, particularly looking at the foot progression angle to understand whether that is normal or whether they have a compensatory abnormal foot progression angle, or indeed whether that is part of their primary issue. Range of movement of the hip is critical, with a particular understanding of internal rotation and its limitations. Impingement testing using the flexion adduction internal rotation test is also very important. The test will be positive in a number of conditions, so it is sensitive though not particularly specific. So if it is negative, then it makes it much less likely that impingement is done. I would examine all patients prone to assess the rotational profile, as this gives a better idea clinically of what the patient's femoral version is, and the difference between that and the supine examination can be very important in understanding the diagnosis. Also, you want to understand the patient's hypermobility status, so assessing the Baton score is important. Moving on to the radiological assessment, plain radiographs are the first port of call for the vast majority of these patients. Plain radiographs give a wealth of information. They can often demonstrate FAI-type morphology, be that pincer or cam. Most X-rays will only be in two orthogonal views, so the full extent of the cam may not be fully possible to assess unless it lies orthogonal to the two views that are chosen. You can get an idea of whether there is undercoverage of the hip, as we'll hear about later, instability or dysplasia, and also whether there are signs of secondary degeneration in the hip. Nearly all of these patients will get a CT scan as well. The axial slices can be very useful to further clarify the acetabular version, as well as looking for cam-type morphology. In combination with slices at the knee and the ankle, the version of both the tibia and the femur can be ascertained. 3D reconstructions, as we can see on the right of the screen, are perhaps the most useful way to have an overall understanding of the patient's morphology, such as the cam-type morphology we can see here. CT data can also be used for motion analysis. There is a number of commercial products available which look to provide further information from the cross-sectional imaging, such as simulating motion analysis and when contact may occur between the acetabulum and the femur, and also looking for the alpha angle, which is a measure of asphericity of the femoral head at various points around the femoral head neck junction to try to clarify the location and size of cam morphology. Also, the software can analyze femoral version and acetabular coverage. MRI is an important part of the assessment and is often the investigation which patients will have as their first investigation, given their young age. It's very important to exclude other rarer diagnoses such as avascular necrosis, stress fracture, or indeed rare things like a tumor. It will sometimes give us some information about the labrum, but that's not the main reason I want to do the MRI scan. It's really to exclude other causes of the conditions. The presence of the or absence of a labral tear will rarely affect the decision making as to how to manage the patient. So moving on to treatment, treatment can really be considered of conservative care, physiotherapy-led rehabilitation, or surgery. So conservative care consists of lifestyle and activity modification, analgesia, including NSAIDs, education, and in some occasions, watchful waiting. An intra-articular injection of local anesthetic and steroid is often helpful both for its diagnostic role and also for its therapeutic role, hopefully in allowing a patient to engage better with physiotherapy-led rehabilitation if some or all of their pain is improved. Physiotherapy-led rehabilitation often focuses on neuromuscular control, range of movement of the hips, stability, strength, and movement. If patients do not get adequate symptom relief of that, then we do sometimes perform surgery for this condition. Now, I think it's very important to understand that not all surgery for femoral acetabular impingement is hip arthroscopy. The key to any surgical addressing of this condition is an understanding of the bony abnormalities primarily and how they might best be surgically addressed. So surgery can consist of hip arthroscopy. Traditionally, consisted of open impingement surgery, though this is very rarely done nowadays. Osteotomy surgery, I think, is increasing in its usage for this condition. That can be of the pelvis, the femur, and sometimes the tibia. If a joint is beyond hip preservation surgery, then hip replacement or resurfacing may have a role in the treatment of this condition. Thinking about surgical selection, There are a number of factors which influence how well a patient might do for surgery for FAI. Considering hip arthroscopy, these are some of the factors which I will think about when trying to decide whether a patient whether surgery is the right thing for them. So a younger age, having a large bony morphology such as a CAM, which is treatable and improvable, is very important to getting a good outcome. Athletic males often do very well with this type of surgery, and the absence of secondary arthrosis on MRI and certainly on radiographs is a very important green flag, as I would consider it. Things which would make me more concerned about the outcomes of surgery might be the patient with a raised BMI, a patient who's had symptoms for a very long time, a negative response to an injection, hypermobility, or previous surgery. Now, that's not to say we wouldn't offer surgery for these patients, but we'd be more guarded about the predictability of the outcome of surgery. So hip arthroscopy can be performed in the lateral position or the supine position. There are a number of things which can be achieved at hip arthroscopy. One is an assessment of the joint and the status of the cartilage. The labrum can be addressed in the form of labral debridement, labral stabilization repair, or labral grafting. And bony abnormalities such as a focal pincer or a CAM can be improved with a high-speed burr to remove excessive bone from the right locations. Cartilage flaps can be debrided, and there is sometimes a role for microfracture. To give some examples of what we see at hip arthroscopy, these are images at the beginning of the procedure to understand the CAM morphology better with orthogonal views, labral anchoring and repairing at the beginning of the procedure to stabilize a damaged labrum, and then a picture after CAM resection with an increased head-neck offset, creating more space at the front of the hip to hopefully reduce impingement and prevent further injury to the labrum and acetabular cartilage. We mentioned version earlier. This is increasingly important in the diagnosis and management of young adult hip conditions. This paper, again from the Burn group, demonstrates that in over 500 individuals who had symptomatic hips, only approximately 1/3 had both normal femoral and normal acetabular version. So indeed, 2/3 had one or more abnormality of version. And we think that this is highly relevant to a number of the problems we see, including hip impingement and hip instability. In the setting of impingement, acetabular retroversion and femoral retroversion can reduce the amount of internal rotation patient can have before contact comes between the femoral neck and the acetabular rim. So all patients with this condition, I would advocate assessing both clinically and radiologically the version. If found to be abnormal, then there may be a role for surgery. So the image on the left demonstrates a patient who has had femoral derotation osteotomies, in this case actually for excessive anteversion, but it is the same procedure performed for retroversion, just the femur is turned the alternate direction. This can be performed over a plate, or sometimes, as we can see on the other image, over an intramedullary nail. Pelvic osteotomy can be performed, so we'll hear more about this from my colleague later, but the periacetabular osteotomy, which is primarily used for developmental dysplasia of the hip, allows reorientation of the acetabulum, and that can be used to correct or improve a retroverted acetabulum in the setting of impingement, which this is felt to be a contributory factor. So briefly talking about the outcomes, there have been two major randomized controlled trials comparing hip arthroscopy with physiotherapy and conservative therapy for femoroacetabular impingement, both of which at relatively short terms, 8 and 12 months after randomization, demonstrated improved patient-reported outcome measures in individuals undergoing hip arthroscopy as opposed to conservative measures, giving some evidence in the short term of the benefits of this type of surgery. Mentioning briefly return to sport, a good proportion of patients treated surgically for femoroacetabular impingement will return to sport, as perhaps as much as 9 out of 10. A lower proportion will return to the same level of competition. Return to sport can, however, take a long time. So it can take almost a year for patients to be able to return to sport. And that's important to understand at the beginning of their journey, that their rehabilitation after these conditions is significant. And professional athletes have a higher rate of return than collegiate athletes. I'm grateful for your time, and I look forward to answering questions later if you were to have any.